Okay, perfect. Great. Excellent.
Yes, we can see.
Okay, great. Perfect. All right. Well, welcome everyone to our
Yes, I can.
Our series of visiting
Yes.
professors for the Buncke Clinic. Today we have the distinct pleasure and honor to introduce my good friend, Dr. Aki Hayashi from the Kameda Medical Center in Kanagawa, Japan. Dr. Hayashi, his expertise is in many things, but most notably, and the reason he's here talking to us tonight, supramicrosurgery use of high-frequency ultrasound and the latest imaging modalities in identifying lymphatics and perforators and so on. And Dr. Hayashi trained with Dr. Koshima, as did our visiting professor from 2 days ago, Hide, Dr. Yoshimatsu, who's also here with us tonight. So, oops, sorry, that's not the, there we go. Okay, good. Now, if you were here for Dr. Yoshimatsu's talk, he mentioned that in his opinion, Dr. Hayashi is like Q from the Bond series, where he has the latest and greatest gadgets and technical toys. And this is definitely true, and that's why we would like him to talk about some of the most recent advances, because these are devices that we don't yet have, but we would love to have, hopefully in the near future. Now, we've already heard from Dr. JP Hong last week, Dr. Yoshimatsu earlier this week or 2 days ago, and to finish this picture, we're now going to hear from Dr. Hayashi. Dr. Hayashi is a dear friend, and he actually spent some time with Greg Buncke at the Korean Society meeting as well. And so we have a close bond with the Buncke Clinic, and I'd like to introduce formally Dr. Hayashi. Aki, I'm going to give you control now of the screen. So give me 1 second here. There we go. Okay, 1 second. We're gonna. You should see the prompt now to be the presenter, and feel free to share your screen.
Okay.
Did it come through? Now, on the bottom of the screen, if you click on the screen button, you should be able to show.
Can you see my slide?
Yet, I don't know if others see it yet or not. There we go. Perfect. Yep, we see it.
We can see it.
Excellent.
Okay, great. Can you hear my voice? Okay.
We can hear you.
Okay. Thanks. My name is Akitatsu Hayashi from Kameda Medical Center, Japan. So I'm honored to do a presentation in one of the finest plastic surgery clinic in the world in this time. And thank you, Obek, for giving me this precious opportunity. So let me do a brief introduction of Kameda Medical Center. Kameda Medical Center was founded in the 17th century during the region of the shogun and samurai, privately owned and operated in Kamogawa City, Chiba, Japan. So the Kameda Medical Center campus includes Kameda General Hospital with more than 1,000 beds, and outpatient clinic features a high-tech diagnostic imaging center and averages more than 3,000 patients daily. So it takes just 1 hour from Haneda International Airport by car. And Kameda Kyobashi Clinic, which is a satellite clinic in Tokyo, opened in 2013. And this clinic is located nearby Tokyo Station, just only 8 minutes using the rapid. So our center directly fronts the Pacific Ocean and medical facility. So there are 30 operation theaters in our center. So last year I had around 35 foreign visitors to our center. If you are interested in today's topic, always welcome to our center, and let's enjoy not only super microsurgery with supervision, but also beautiful landscape and seafood. Okay, at first, I will talk about my current approach to lymphedema. So nowadays, around 25% of patients who had breast cancer and gynecologic cancer will have lymphedema. So it has been reported that lymphedema affects as many as 200 million people worldwide. So lymphedema diagnostic market has been getting increased up until now and from now on in whole over the world. So the strategy of our lymphedema center is, one is establishment of early diagnosis. Second one is design of more effective surgical treatment. So especially, I have put my effort into third one using imaging modalities. So over 90% of lymphedema cases are cancer-related lymphedema, and most of them are obstructive lymphedema. The lymphatic vessels become sclerotic over time after lymph flow obstruction. So in the process of thickening of tunica media, the lumens of the lymphatic vessels turn to be narrow gradually and lose their function to push the lymphatic fluid to center of the body against the gravity. So considering current lymphatic condition and subcutaneous tissues, I choose a single procedure or combination. So lymphatic venous anastomosis works well for the patients who have less sclerotic lymphatic vessels, but doesn't work so much for the patient who has much sclerotic lymphatic vessels. So in these cases, lymph node transfer is the first choice. But nowadays, I prefer to do lymphatic system transfer as Hide et al. So I and Hide published this procedure last month. So this case is most severe cases 2 years ago in Kameda Medical Center. She had house stay surgery 25 years ago. And she couldn't come to my outpatient clinic without holding her hands and arm. So we did lymphatic system transfer, skip-based trap, including the 2 or 3 lymph nodes, and also including 3 or 4 afferent lymphatic vessels going into lymph node. So we put the lymphatic system like this. And after the surgery, I did immediate compression from hand to forearm, and lymphatic fluid going up from the afferent lymphatic vessel. And go up through the lymphatical venous anastomosis and lymphatico-lymphatic anastomosis. So this is a post-operative course, 1 year and 2 years. So please see the upper arm. You can see the compression line in the upper arm, but now post-operative 2 years, we cannot see the compression line because patients started to wear off the sleeves from the post-operative 1 year, step by step, and from half years ago, she weared off the compression therapy completely, like this. So this is post-operative result in the outpatient clinic. Okay, so compared with lymph node transfer and lymphatic system transfer, LVA is the least invasive lymphatic surgery. and considered first for compression refractory lymphedema. On the other hand, less bypass effect can be expected with a sclerotic lymphatic vessel in progressed cases, as I told before. Recently, many super microsurgeons told that lymphatic venous anastomosis doesn't work so much. That's why there is a trend toward lymph node transfer. I think this is wrong because most of them haven't detected appropriate lymphatic vessels before surgery. If we try to find functional and less regular lymphatic vessel, which is responsible for lymphedema more precisely, we can maximize the efficacy of LVA, even in moderate to severe lymphedema. For success of LVA, identification and determination of less sclerotic and functional lymphatic vessels and suitable vessels and veins are important key. In other words, anastomosis in the severely sclerotic lymphatic vessels leads to minimal therapeutic effect in LVA. Okay, so next I will talk about new imaging techniques for LVA. So especially I have focused on the lymphatic surgery with supervision. The concept of LVA is very simple, as you know, but I think many microsurgeons experience lack of result, even if they found lymphatic vessels for anastomosis in the operative field. If result of LVA is not good, it's probably the result of lack of attention to a specific details. This is a key to maximizing the effect of LVA, and imaging technique is one way to approach specific detail. I never doubt that in LVA, God truly is in the details. So for selection of lymphatic vessel, preoperatively, simple handling, convenient, and real-time imaging are very important for surgeon. So ICG lymphography is a minimally invasive imaging modality that can determine the location of the lymphatic vessels as linear pattern. As lymphedema gets worse, it cannot show precise lymphatic flow because lymphatic flow is masked beneath dermal backflow. So surgeon usually uses immediate ICG lymphography before the surgery, of course, and try to find a lymphatic vessel which has lymph fluid leak in proximal. As you know, it is easy to find in early stage using immediate ICG lymphography. But it is difficult to find in the moderate to severe cases, which showed immediate dermal backflow after injection of ICG, as you know. From this viewpoint, ICG lymphography is the most popular modality for that. But maybe you know ICG lymphography is not perfect. The recent study from Taiwan reported that lymphatic flow positive but non-ICG enhanced lymphatic collecting vessels should also be considered as functional. And more, we cannot detect appropriate vein using ICG lymphography. So I think we need more information for effective lymphatic surgery. For detection of lymphatic vessels, I postulated that ultrasound, which is more common and simple, could be a complement and substitute for ICG lymphography preoperatively. I'd like to start it by looking at the history of ultrasonographic detection of the lymphatic vessels. So this is a historical paper of ultrasound detection. Goldberg reported ultrasonographic imaging of lymphatic vessels of animal using contrast medium in 2005. So next, Siever reported visualization of lymphatic vessels going into sentinel lymph node of human, also using contrast medium in 2010. So in 2014, I started to try to detect lymphatic vessels without contrast medium using conventional high-frequency ultrasound. Because ICG lymphography taught me that examination using contrast medium cannot detect full lymphatic vessels. But I didn't convince so much at first, so I always inject contrast medium or ICG lymphography to my foot or hand every time for checking my detection was correct or not. So from 2015, we started to report ultrasound visualization of lymphatic vessels without contrast medium. So at first, the result of our first study using high-frequency ultrasound targeted at healthy volunteers indicated that ultrasound-guided detection of lymphatic vessels without contrast medium can be performed with high precision. It showed the possibility of detecting lymphatic vessels under dermal backflow pattern of ICG lymphography in affected lymph site of lymphedema. This video showed that, This video showed that 80 MHz probe is detecting lymphatic vessels going into lymph node in early stage of lymphedema. So lymphatic vessels are never colored by color Doppler mode because of its slow speed, but most of people couldn't believe that ultrasound can detect lymphatic vessel without contrast medium. Even I show this kind of movie. So for selection of lymphatic vessel, now I use ultra high frequency ultrasound. What is the ultra high frequency ultrasound? I remember that when I checked my median nerve using this machine 3 years ago, it was I was convinced that we can see everything more than ever before. This imaging technology is amazing and almost like histology. So with a 70 MHz transducer, which has capabilities, resolution as fine as 30 micrometer, 48 MHz transducer as fine as 50 micrometer. So this ultrasound showed completely another world and could permit more precise detection of the lymphatic vessels. Lymphatic vessels were not colored by color Doppler mode because of its slow flow speed. And most of lymphatic vessels were less likely to collapse when the transducer was against the skin of the examined sites. So the big question in our research was, why no completely collapse and luminal expansion of lymphatic vessel? So previous study of basic research already showed that lymphatic flow was positively correlated with regional tissue pressure. So if the pressure frequency was greater than the spontaneous contraction frequency of the initial lymphatic vessels, the lymphatic flow could increase. So tissue pressure using transducer could be one of good way to differentiate the lymphatic vessels from others. So there are two frequently asked questions. The first one is how to differentiate from vein. So if using this ultrasound, it is very easy because this ultrasound cannot detect the flow speed of lymphatic vessel. So even if we don't use the color Doppler mode, we can differentiate the lymphatic vessel from the vein, because in the vein we can see mosaic pattern, and this is lymphatic vessel. In lymphatic vessel, we cannot see mosaic pattern because ultrasound cannot detect the flow speed of lymphatic vessel. And if this lymphatic vessel is a vein, this lymphatic vessel is a vein, this will converge into this vein, but not converge into this vein, and also not converge into this vein, and converge into another lymphatic vessel, like this. Okay, so the second question is how to differentiate from the nerve. So the answer is the layer. Okay, this is vein and this is lymphatic vessel. And vein is usually run over the superficial fascia again. And this is superficial fascia, and this is vein. And this is lymphatic vessel. Lymphatic vessel usually runs under the superficial fascia. And nerve runs over the deep fascia, this one. So for differentiate from other structures, the layer is very important. And in the lymphatic vessels, low echoic area can be detected while narrows and spreads when I move the transducer longitudinally. So in the cutaneous single nerve, we can see almost the same shape of low echoic area. So we can differentiate very easily. So I started to apply this technique to the secondary extremity lymphedema patients preoperatively. Again, anastomosis in the severely sclerotic lymphatic vessels leads to minimum therapeutic effect in LVA. So from our studies, compared with the histological study, high echoic region around the low echoic region show degenerative status of smooth muscle cells and hyperplasia of collagenous fibers in the lymphatic vessels. So we can select the best lymphatic vessels in each point preoperatively using this ultrasound. So above all, this ultrasound could detect movement of the lymphatic vessel with valve functioning in around 25% of lymphedema cases, ISL stage 1 and stage 2A, 2B in our study. This is enlarged image. So we can check the function of the lymphatic vessels even if it has already damaged. So this is a longitudinal image. So we can see the peristaltic movement, and also we can see where is the valve. This is another image. Here is a valve. You see? You can see the moving of the valve inside of lymphatic vessel. Okay, so preoperative checking of vein, which has appropriate size and less backlog, is also very important. So here is the main trunk of subcutaneous vein. And here is a branch from this trunk, and which has valve. So surgeons can select good vein for LVA preoperatively very precisely. So this is a practical example. This case is moderate secondary upper limb lymphedema. ICG lymphography showed immediate dermal backflow after injection of ICG in forearm, although we couldn't check any lymphatic route here using ICG lymphography. But we could see not only lymphatic vessels under superficial fascia, but also size matching vein, which is the branch from main trunk. So we could detect them very precisely around 3 mm below the skin. And this is an intraoperative picture after dissection of lymphatic vessel and vein. So you can see they were located as ultrasound indicated. So even if we can know the location of a lymphatic vessel using ICG lymphography in early to moderate stage, this ultrasound is also useful. So in this case, I can see the lymphatic vessel using ICG lymphography, but only one line in ICG lymphography. But in this ultrasound, we can see 3 lymphatic vessels, 1, 2, 3, and 2 veins. So in one route of ICG lymphography, 3 lymphatic vessels in ultrasound. So this is a vein, and these 3 are lymphatic vessels. And after that, of course, we could detect the lymphatic vessel and appropriate size of lymphatic vessel and vein. So we can anastomose very precisely. And also, we can know where is the obstructed point. Before obstructed point, lymphatic vessels are usually very expanded. So this is an obstructed point. Okay, I showed again. This is expanded lymphatic vessel, and you see, not collapsed, and you see, and converge together, and after that, totally obstructed. So we can know where we should decide the anastomotic point. How should we do? No venue has been found nearby. How should we do? No venue nearby the lymphatic vessel. So no venue has been found nearby lymphatic vessel, even if using ultra high frequency ultrasound. In this situation, we use venue rerouting method. So the two planned incisions have been performed to dissect and transport the recipient venue identified preoperatively by ultra high frequency ultrasound. So LVA has been established. ICG is found beyond the rerouted venue, showing optimal anastomosis function. So we published this last week with Giuseppe Visconti. So next is intraoperative planning using new imaging techniques. So microscope integrated ICG fluorescence imaging or other ICG fluorescence imaging tools are often used for this purpose intraoperatively. Although ICG enhanced lymphatic vessel has been considered functional for its capability to transport contrast-contained lymph, and non-ICG enhanced lymphatic vessel non-functional. So I applied ultrasound technique to also intraoperative imaging because sometimes we cannot get clear image preoperatively in stage 2B and stage 3. So who have thickened skin and severe fat deposition. So sagittal and axial BMO scans are performed on the dissected lymphatic vessels directly before LVA. So in our previous study, the correlation between the thickness of hyperechoic region in intraoperative image and the thickness of smooth muscle cell of the lymphatic vessels in histology was investigated. So as the hyperechoic region of the lymphatic vessel grows, the thickness of smooth muscle cell of the lymphatic vessels in histology was likely to increase. From this result, high echoic region, which was seen in preoperative imaging in lymphedema patients, may show degenerative status of smooth muscle cells. So this video shows practical example of intraoperative detection. Two lymphatic vessels were dissected and are on the green sheet. So surgeon thinks about which lymphatic should I use for LVA, which is less sclerotic. So next, surgeon definitely turn on PD mode for checking ICG fluorescence, but it showed nothing. How should surgeon do next? Using next classification or checking patency or other uncertain ways? So this is green sheet. Above one showed more hypoechoic region. Instead of that, below one showed less hypoechoic region and more hyperechoic region. So very easy to select. Of course, we select above one for anastomosis. So this ultrasound can detect not only lymphatic vessel, but also 12-ball thread, 15 micrometer needle. So this white dot is 12-ball thread. And when I try to detect the anastomotic point, this ultrasound can show very clearly. So this white dot is a thread, and this is short axis. So you can see 4 anastomotic point. So it means that anastomotic point is very clear and precise anastomotic condition. So from our research, ultra-high frequency ultrasound enables selection of less corrosive lymphatic vessels, selection of the vein features appropriate size for lymphatic and less backflow, effective and efficient surgery in minimum scar, so in the lymphatic super microsurgery. So when I began to use ultrasound for lymphedema surgery, my surgical results improved dramatically. The limitation of ultra-high frequency is maximum depth. So 30 micrometer for 70 megahertz, 27 millimeter for 48 megahertz. So we should use each transducer differently for each part. In this area, in Thai area, I sometimes use high frequency ultrasound when I cannot see anything in 48 megahertz. But in most of those cases, severe fat deposition already occurred. So I cannot detect lymphatic also in high frequency. So this is 48 megahertz in stage 3 lymphedema patient. You can see so much lymph fluid and fat deposition, but we can see lymphatic vessel very clearly. You see, this is a lymphatic vessel, 2 lymphatic vessel you can see, right? And run together with another lymphatic vessel, and this is vein. So I can make lymphatic venous anastomosis very precisely. This is a more severe case. So depth is around 1.7 centimeter. You see, this is vein, and this is lymphatic vessel. When I push the vein, the lymphatic vessel doesn't collapse so much, and you can see mosaic pattern in vein. You cannot see mosaic pattern in lymphatic vessel. Very easy to differentiate. So if you start out with patient with severe lymphedema, you will take a lot of time to learn the ultrasound technique. But if you start using ultrasound in less severe patient, you will learn much faster. This is my advice. Okay, today I will present new technology using laser tomography. So I hope this will be published soon. So this is my operation theater. So this is Pentelo 900, and this is a PD machine, and this is ultrasound, and this is a new microscope. So probe of the ultrasound device has to be placed directly on the lymphatic vessel, which was soaked in saline. Thus, disadvantages of ultrasound system is time consuming for intraoperative detection of lymphatic vessel. So I present new capabilities of laser tomography for imaging of the lymphatic vessels for intraoperative selection of appropriate lymphatic vessels, which may outshine conventional techniques. So laser tomography has significantly refined clinicians' approach to diagnosis and management and surveillance of ophthalmic disease at first. So we thought that laser tomography could provide specific real-time guidance for surgical manipulations and selection of functional lymphatic vessels for lymphatic venous anastomosis without contrast medium. So in our study, lymphatic venous anastomosis was performed assisted by a laser tomography, which was combined with microscope, thus allowing intraoperative real-time imaging with immediate feedback on the monitor. So this is a real-time image of the lymphatic vessel on the monitor. So the black and white scale expresses the strength of the reflection of near-infrared light against subject objects in this system. White color represents the most intense reflection, and black color represents the weakest reflection. So this system provides an imaging depth of 2.5 millimeter at an optical axial resolution of under 4 micrometer. So in our discovery study, the diameter of the lumen and thickness of the lymphatic vessel wall were measured after using vasodilation drug and recorded during surgery at first. A small portion of the lymphatic vessel which were used for LVA were obtained and sent to histology after finishing OCT scanning, and the samples were stained with elastic muscle for evaluation of degenerative changes of smooth muscle cells and hyperplasia of collagenous fibers in the lymphatic vessels. So the thickness of the lymphatic vessel wall was measured and documented by histologists. The correlation between the thickness of the lymphatic vessel wall obtained via laser tomography and the histologically measured thickness was examined in over 100 cases. So the correlation was good to excellent with significant difference. The result revealed that laser tomography can provide objective information regarding the thickness of lymphatic vessel wall. So from this preliminary study, it was revealed that there are some main benefits of laser tomography for lymphatic venous aneurysms. You can avoid harming the fragile lymphatic vessels even if they exist in superficial layer. And you can select the less sclerotic lymphatic vessel in the same operative field. So, although 3 lymphatic vessels were similar in appearance under microscope integrated laser tomography showed that they have different lymphatic degeneration status. So, surgeon can know which lymphatic vessel they should select for LVA without cutting. Moreover, this machine could clearly visualize and identify the valves of the lymphatic vessels, so surgeon can know precisely where they should cut the lymphatic vessels for end-to-end anastomosis and avoid damaging valves when making a window in the lymphatic vessels for side-to-end anastomosis. There are 2 lymphatic vessels in the same operative field. And above one show the above one has a good valve, and below one has no valve. Of course, surgeon can select the lymphatic vessel which has valve. And also, this is a very strong point, I think. This machine can evaluate the anastomotic condition of LVA. This is end-to-end anastomosis. This is inverted anastomosis, and this is less inverted anastomosis. So it means that inverted anastomosis will have some possibility of obstruction of the anastomosis point. So, and if we adjust the cross point of the square, we can see the anastomotic point in the short axis. So this white dot is a suture thread, and you can see the black hole in very clearly. So it means that anastomotic point is very nice. Also in the short axis. Long axis showed also very nice image. And also can show the anastomotic condition of side-to-end anastomosis. Okay, so this is my current protocol of imaging techniques. So getting the big picture using lymphoscintigraphy and ICG lymphography is of course important. Finding the lymphatic vessel which is responsible for lymphedema and selecting the lymphatic vessels that can be expected to be effective for surgery. So new imaging technologies, ultrasound and laser tomography can visualize detail of the lymphatic vessels and bring us more information for maximizing efficacy of lymphatic supermicrosurgery. I never doubt that these new techniques take the surgeon to next level. So this is conclusion. Ultrasound enables to diagnose of full degeneration status of the lymphatic vessels, although you can evaluate and select the best lymphatic vessel for lymphedema supermicrosurgery in operative field. So this technique may help more effective surgery preoperatively and intraoperatively. Also, the laser tomography provides images with extremely high resolution, allowing precise appraisal of the lymphatic vessel and the quality of anastomosis and effective LVA. I believe that ultrasound and laser tomography are game changer for lymphatic surgery. So this book will guide you in basic principle and provide you with surgical technique and logic behind the surgery. So most of all, it will help you build your fundamentals in lymphedema surgery that you will take along for your future journey as a lymphedema surgeon. Thank you very much.
Wow, Aki, thank you so much for that. That's it's really incredible to see all the incredible advances in imaging technology. This is way ahead of anything that we have here in the U.S. So we're all very envious. I want to congratulate you on all the work you've done to really push the envelope, because it's no longer good enough to do an LVA, but now you're able to do an LVA on a lymphatic channel that you know is less sclerotic, and you know you're not at the valve and all that kind of stuff, and you can even evaluate the anastomosis through the laser tomography. So that's really incredible stuff. A quick question for you. A quick question before we open it up to the audience members as well. Since you've been using the high frequency ultrasound and laser tomography to really identify the quality of the lymphatic channels, have you noticed an improvement in your outcomes?
Yes, I already showed the outcome with high frequency ultrasound. But now I'm writing about the ultra high frequency ultrasound for long time post-operative course.
Yeah.
And totally different with high frequency ultrasound, especially in upper arm lymphedema.
Got it. I see. Interesting.
Yes, upper limb lymphedema. And sorry, I started laser tomography study from one year ago. Mm-hmm. So please wait for a long time result.
Okay, we'll definitely stay tuned for that. One of my partners, Dr. Walter Lin, has a question. Walter, go ahead.
Okay.
Thanks, Babak, and thanks. That was a truly amazing talk with a lot of groundbreaking technologies. So thank you. I was just wondering, we were fortunate enough to have a talk from JP Hong, who also just started using the ultra high resolution ultrasound, and he mentioned he prefers the deep lymphatics, and I was wondering whether you've characterized the deeper lymphatics and how they compare, and also if you, I noticed your examples look like they're mostly superficial lymphatics, and I was wondering if you would agree there is a difference between the superficial and deep lymphatics for LVA.
Mm-hmm. Mm-hmm. Yes, I totally agree with your opinion. So, from my opinion, 90% of the cause of lymphedema is superficial lymphatic vessel, but the rest is caused by a deep lymphatic system. So because when I do IgG lymphography, sometimes lymphatic going into a deep lymphatic vessel, so we cannot see the lymphatic vessel immediately, but no dermal backflow. But no dermal backflow in distal side. But in proximal side, suddenly dermal backflow will start. So it means that I think deep lymphatic system is a cause of lymphedema in these cases. So, of course, ultrasound and ICG lymphography cannot detect the deep lymphatic system. So if we want to detect the lymphatic system, we have to use the SPECT CT, I think.
And have you happened to so you never used the deep lymphatic system in that case?
No, if the ICG lymphography showed, or maybe this case is caused by damage of deep lymphatic system, I sometimes use deep lymphatic system using a SPECT CT imaging in especially in upper arm.
Okay, thank you.
I'd like to welcome Dr. Sue Jordan, one of our colleagues from Northwestern. Hi, Sue. Welcome. Thank you for joining us today, or tonight for you, I guess. Greg, do you have any comments? You're muted, Greg. If you take yourself off of mute for a second. Perfect.
Aki, thank you so much. Great talk. Really, as Walter said, really groundbreaking new stuff that we have not been able to use yet, and looking forward to using it. Is it available in the United States?
Yes, of course. I already pushed the American company of the Fujifilm Sonosite, and I think they will start to promote and sell. Yes,
Okay.
and if you want, I will connect.
Well, I'd love that. Even the laser Doppler? I mean,
yes, you can get that. You can get that from the Leica. So Leica and Zeiss, both company has laser tomography system. The microscope, including laser tomography system. I checked both. I think in current situation, Leica is better, totally better.
Got it.
I see.
Yeah. So I think this is also very, very useful for microsurgery, I think.
Oh yeah.
Yeah. So please proceed as a study using this microscope in your clinic, because I don't have so much reconstructive cases except for lymphedema.
So it should work well for vessels as well. It's very, very small vessels.
Yes. You know, okay, so for example, for doing the surgery for diabetic foot or reconstruction for diabetic patient, we have to choose the good recipient vessel, right?
Right.
Yeah, so we can select, I think we can select using this microscope.
Fantastic.
Yeah.
Yes.
Thank you again,
Absolutely.
Aki.
Yeah, thank you, Greg. Nice to see you again.
Nice to see you too.
Aki, I have a question from one of our colleagues at UCSF, Dr. Esther Kim. And she's asking, you know, if someone is going to start doing LVA in the US, but they don't have a high frequency ultrasound, what protocol would you recommend for them to start with?
Okay, so I think started by using high frequency is better, but you know, it needs at least 80 megahertz. Not, we cannot detect 10 megahertz, 12 megahertz, 50 megahertz. I think we need 80 megahertz for superficial mode. And as I told before, we should detect the lymphatic vessel using healthy volunteer or using stage 1 or stage 2A patient at first.
Okay.
If you detect the severe lymphedema patient, I think you cannot know at first. But after training using early stage patient, you can see the lymphatic vessel even if severe lymphedema patient.
Got it. Okay, thank you so much for that. We have another question from one of our fellows, Dr. Danny Balkin.
That was a extraordinary talk, and I'm blown away by the correlation between what you see clinically in the operating room and the histology, and that is a beautiful depiction of what the vessels look like under the microscope and in the OR. I have 2 questions for you. The first is, what's the resolution limits of your tomography? And second, you know, in high resolution super microscopy, they've been able to defeat the limits of static imaging with certain sleight of hand so that you can see real-time imaging. For instance, the ability to do like scanning confocal microscopy in order to actually see real-time visualization. Is there a way to actually see the flow with the tomography, or is it just a static image?
Okay, very nice question. So okay, for second question, unfortunately, we cannot see the flow. We cannot see the flow speed even if we use laser tomography. And for the first question, I have data. So this system provides an imaging depth of 2.5 millimeter at an optical axial resolution of under 4 micrometer. So images are acquired at 32,000 cross-sectional scans per second. So the scan length is up to 16 millimeter. So 16 millimeter is enough for one operative field.
Yes.
Right.
Yes.
That's awesome. Thank you.
Yeah, can't wait to get the technology here in the U.S. for us to use it. Any other questions from the audience since we have our expert, Dr. Hayashi, here? Okay, looks like that's it. Aki, I want to thank you again for joining us. It's really an honor and a privilege to have you, and we've learned quite a bit, and I want to congratulate you on really advancing the field of imaging and pushing the envelope. And I look forward to hopefully visiting you at Kameda Medical Center in the near future once everything quiets down a little bit. And I also look forward to seeing both you and Hide hopefully in Kauai for ASRM.
Yes.
Great.
Thank you very much.
So much.
It was very honored to do presentation here, and I also looking forward to visit your clinic next year.
Excellent. We'd love to have you. Great.
Thank you very much, Greg.
Have a great day and good luck with
Thank
your
you.
cases
Nice to see you, Aki. Really great talk. Thank you.
Okay.
Thank you very much.
Bye, everyone.